Respected chairperson, resource persons, and delegates, at the outset, let me say good morning from India and thank the organizers for inviting me to deliver the talk on controversies in cooling in low and middle income countries. Controversies are often created by people and individuals, either knowingly or unknowingly. Anyway, all controversies will lead to publicity. Why perinatal asphyxia is an important issue? In developing countries like India, HIA accounts for 30% of neonatal deaths, and 30% of the babies with HIA develop disability. Among severe HIA cases, 60% are handicapped. Perinatal asphyxia is an insult to the fetus or newborn resulting from the lack of oxygen and or perfusion associated with hypercapnia and acidosis. Usually, the umbilical artery blood pH will be less than 7 with a base deficit of more than 12 millimole per liter with a low UPGA of 6 or less at 5 minutes. Many of them will have neurological disability, abnormality, and multi-organ dysfunction. The incidence may vary from 0.5 to 2% in developing countries like India. It may be around 14 per thousand live births. It's almost 10 to 15 times higher than the developed countries, and 90% of them are antenatal or intranatal. Why infants sustaining perinatal asphyxia have different outcome? We should understand there are two important things in perinatal asphyxia pathophysiology. One is the primary energy failure, another is the secondary energy failure. Primary energy failure is the initial response of the infant, fetus or infant for hypoxic insult. Once the insult is relieved, the infant may recover from the initial insult. This is followed by a latent phase and secondary energy failure. During secondary energy failure, there is neuronal death, which will result in permanent damage to the brain. So whatever we do for benefiting the fetus or infant should be during the first 6 hours of hypoxic insult. If you look at the pathophysiology of hypoxic ischemia, there is significant anaerobic glycosis and increased lactate release. It may act on the adenosine pathway or decrease in the ATP and increase glutamate. But whatever mechanism it acts, finally there is a release of free radicals, which ultimately causes brain damage and disability. Various organs get affected in hypoxia. Kidney tops the list. Almost 50% of the infants with significant hypoxia will have renal damage. Brain, cardiovascular, pulmonary system may affect in about 25-28%, but most of this organ damage you will recover probably with persisting damage in the brain or neurodevelopmental outcome. Initially, we looked at various factors which will predict the outcome in perinatal asphyxia. We looked at the myocardial function, we looked at the nucleated red cells, we looked at renal parameter, oxidative stress, renal excretion of protein and uric acid, biomarkers, and DNA damage. We looked at the electrocardiographic and echocardiographic changes in perinatal asphyxia and also the various enzyme levels. All babies who expire due to asphyxia had myocardial dysfunction and cardiac involvement correlated well with the neurological outcome among the survivors. We also looked at the enzyme levels, the cardiac troponin and CKMB levels. They are also significantly increased in perinatal asphyxia. Cardiac troponin level shows better sensitivity and specificity compared to CKMB. The ECG echocardiogram changes which occur in perinatal asphyxia will return to normal in most of the cases. Nucleated red blood cells increase due to stress, and more the nucleated red cells, poor will the outcome. Similarly, we looked at the urine MDA, creatinine, uric acid, protein levels. They are also increased, and increased levels indicate poor outcome. We also looked at the oxidative stress level, melandialdehyde, and protein carbonyl in the cord blood in cases with and without hypoxia. The MD and protein carbon levels were significantly higher among cases and gradually increases with the time, and expired infants and those who had developmental delay had significantly higher levels. We also looked at the renal functions, which is the most common organ damage in perinatal asphyxia. The blood urea, serum creatinine levels are altered in infants who had hypoxic ischemic encephalopathy or HI, and the urine beta microglobulin has better sensitivity in predicting the outcome. Acute kidney injury, roughly in our studies, occur in about 56% of the asphyxiated infants, but all infants who expired had renal damage. Later, we looked at the DNA damage in perinatal asphyxia because some of these infants who sustain brain injury, which are severe enough, do not recover. So we looked at the we did comet assay, micronucleus assay, karyotyping, looking at the renal damage. Comet assay is important because it does not require cell culturing. So you take the blood, separate the leukocytes, do alkali denaturation, and put electrophoresis. The damaged DNA will move away from the nucleus. The longer the tail, which gives the appearance of a comet, indicates DNA damage. As the DNA damage is more severe, the diameter of the head or the nucleus becomes smaller, the percentage of DNA in the nucleus decreases. If you look at these pictures, these are typical of a comet assay. The first one is a normal cell which is more rounded, and as the hypoxic damage occurs, the comet appearance develops. The smaller the tail, minimum is the damage, and the longer the tail, severe is the damage. We also looked at micronucleus. Micronucleus is a small nucleus in a bilobed cell, and micronucleus indicates cell death in cell death. So the more micronucleus, more damage to the cell. So as the hypoxic stage increases, or those who have severe conversion, they will have higher number of micronucleus, or it indicates poor outcome. The more micronucleus, poor the outcome. We have also looked at the karyotyping. It shows, as you can see in the picture, the interchromatic connections, the chromosomal breakdown, dicentric chromosomes, ring chromosomes. The various abnormalities are seen significantly increased number of chromosomal damage in cases of hypoxia. So so far we were looking at the outcome and the prediction of poor outcome, but later we try to see what can be done for these infants. So we started doing therapeutic hypothermia. Unlike other treatment, if you look at hypothermia, it acts at various levels of hypoxic ischemic encephalopathy pathophysiology, like it reduces the anaerobic glycolysis, it reduces the glutamate level, it acts on the NMDA receptors, it reduces the lipid peroxidation, and it also acts on nitric oxide synthase, nitric oxide pathway. So it has action at multiple levels. That's why we find good response when you do therapeutic hypothermia for these infants. You must remember, when you do therapeutic hypothermia, there is an induction phase, maintenance phase, and rewarming phase. The induction phase should be rapid. Within 45 minutes, 1 hour, you should cool the baby to the target temperature 33 to 34 degrees, maintain at 33 to 34 degrees for 72 hours, and gradually rewarming. It should be done within the therapeutic window period, normally less than 6 hours of insult, hypoxic insult in the window period, after which the secondary energy failure sets in. You must remember the rewarming should be very, very gradual. It may take as much as 6 to 8 hours to rewarm the infants. The longer you take, the better it is. If you rapidly rewarm, all the beneficial effects of cooling will vanish. So, initial rapid cooling maintains at 33 to 34 degree centigrade and gradually increase the temperature over 6 to 8 hours. Initially, we did not have the servo control tools or fast staging materials, so we use the gel packs which we use in our country for carrying the vaccine to the field. So usually an infant will require about 3 gel packs to bring down the temperature to 33 to 34 degrees. 2 are kept in the back and 1 under the head, and these infants are connected to a continuous multi-parameter monitor which monitors the rectal temperature, surface body temperature, heart rate, respiratory rate, oxygen saturation. All this have to be continuously monitored. Initially, we randomized 65 infants to hypothermia and normothermia treatment, and they followed them up for 6 months. Therapeutic hypothermia showed very significant reduction in combined rate of death and developmental delay at 6 months of age, and the benefit was almost 21% compared to the uncooled infants. Initially, we did not have a good number of ventilators, so many infants who are very sick we could not cool, and a larger number of moderate hypoxia babies were included. And if you look at the mean developmental score, developmental age, developmental quotient, all are significantly better in cold when compared to the control. Even looking at impaired hearing, impaired vision, the number is less in hypothermia group, but of course they did not reach statistical significance. Number of convulsions were less in hypothermia group, number of anticonvulsant required were also less. We later started looking at oxidative stress in these infants, in the cold and uncooled babies, and if you look at initially at the base level between the cold and uncooled infants, the level is almost similar, there is no difference, but that time passes, the oxidative stress in the hypothermia group does not increase, whereas in the cooled normothermia group, it increases. There is increase in oxidative stress and reductions antioxidants, and outcome was significantly better in those infants who are cold. Later, we looked at the DNA damage, which we have found earlier as a prognostic markers among the cold and uncooled babies. And if you look at the DNA damage, there is no further increase in the therapeutic hypothermia group, whereas uncooled babies, the DNA damage continues to increase, causing more and more damage. And we correlated the tail length, which indicates DNA damage, with the mental and developmental quotient. And as the tail length increases, the developmental quotient, mental and motor developmental quotient, they come down, or they are inversely related. More damage to the DNA, poor is the outcome. So therapeutic hypothermia reduces oxidative stress, it reduces the DNA damage, it improves the outcome, long-term outcome of these infants who are cold. And DNA damage and oxidative stress had significant negative correlation with the developmental age and developmental quotient. People often believe that renal injuries increase with the therapeutic hypothermia. So we randomize this group into cooling and non-cooling to look at the renal functions. The renal function abnormalities are significantly less among the cooled infant compared to uncooled infants. So the renal damage is not related to cooling, but it is related to the hypoxic insult. We also looked at the myocardial dysfunction in the cooled and uncooled babies. The CKMB and troponin levels are significantly lower in the cooled babies, and the ECG and echo changes are also lesser among the cooled babies when compared to uncooled babies. So there is less DNA damage, less renal abnormality, less myocardial dysfunction in cooled babies compared to uncooled babies. Now you may ask me whether there is no complication due to therapeutic hypothermia. There are complications in those cooled and uncooled babies, but most of them are related to hypoxia and not due to cooling. There is some fall in platelet count. There is significant bradycardia. Some skin changes may occur among those infants who are cooled with the gel pack if it comes in direct contact with the skin. So only significant change between the cooled and uncooled babies, or because of cooling, what we have found is sinus bradycardia. If an infant under cooling does not develop bradycardia, it means that probably you are not cooling the baby properly. All infants who are cooled should have bradycardia. All the other changes which occur between the cold and cooled babies are almost similar. So it indicates that it is more related to hypoxia rather than cooling. So to have normal outcome, we need to cool 6 infants. So one infant will be normal if 6 infants are cooled. So the number to be treated is 6 in cooling. There are two systematic review and meta-analysis in relation to cooling, one by Jacob et al. And by Abed et al. Therapeutic, according to Jacobs et al. Publication, therapeutic hypothermia reduced mortality without increasing major disability among the survivors. The benefits of cooling on survival and neurodevelopmental outcome outweigh the short-term adverse effects. So it is strongly recommended that hypoxic infants who sustain perinatal hypoxia should be treated with cooling. About at all analyze and the systematic review more related to developing country, most studies from the developing countries, and it concluded that low income countries the benefit will be most from therapeutic hypothermia because the number of infants sustaining hypoxia insult are much more, and it is likely to be beneficial. And if you compare the outcome, the mortality in various studies, only the Helix trial and their earlier trial with using phase changing material did find increased mortality, where all the other studies, the mortality was less compared to uncooled babies. Similarly, when you looked at the neurodevelopmental outcome, all studies showed better neurodevelopmental outcome, including the Helix trial. Even in the Helix trial, among the survivors, the neurodevelopmental outcome was better among cooled infants compared to uncooled infants. Then what went wrong with the Helix trial? Fallacies in the Helix trial. If you look at the data, 70% of the babies schooled were outborn. See, umbilical cord pH was available only 10% of their cases. High proportion of babies having clinical seizures converse in that environment. This indicates most of these infants who are cooled already had significant brain damage, and 80% of the neonates had white matter injury, suggesting a subacute and partial prolonged hypoxia. There is no mention of intrapartum fetal monitoring, mode of transport, monitoring during transport, unless an infant given proper care after delivery, immediately after delivery, properly given supportive care, the outcome will be bad because the continued insult causes a further damage to the brain. So the poor care at birth can aggravate primary injury before therapeutic hypothermia can prevent hypothermia. Probably this explains the poor outcome in Helix trial conducted in some of the developing countries. Now the question comes, should hypothermia be routinely offered to infants with HIE? I suggest that I tell this audience that it should be offered to term neonates if they come within the therapeutic window of 6 hours, they have severe acidosis or need for resuscitation at birth, and if they have moderate or severe encephalopathy. One should remember it should be given only in centers where there is enough facility for monitoring and taking care of sick infants. So this is an article which we wrote in the Indian Journal of Pediatrics, where we set the requirement for therapeutic hypothermia treatment in any healthcare center. There should be neonatologists, trained nurses should be available, cooling devices should be available, proper monitoring, and also there should be good follow-up of this infant to see what happens to them later. So in conclusion, I would say perinatal asphyxia is an important cause of neonatal morbidity and mortality, especially in low and middle income countries. Oxidative stress-induced DNA damage is an important mechanism causing brain injury. So whatever you use, if you can reduce the oxidative stress and the resulting DNA damage, the outcome will be good. Our aim should not be to treat infants with hypoxia, but identify high-risk pregnancies and try to transfer these high-risk mothers to an appropriate center for proper delivery. And therapeutic hypothermia will definitely reduce long-term morbidity and mortality even in low middle income countries. Believe that human beings are same whether they are in developing countries or developed countries. Maybe we have poor nutrition, more infection, other problems. So the result may not be directly comparable, but definitely it is comparable to most developed countries as per the many studies which are conducted in our institution. I thank many of my colleagues from various departments like anatomy, biochemistry, pathology, cardiology, and various faculty members and residents who worked with me in conducting all these studies. Uh, Thank you once again for your patient hearing. Thank you very much. If any questions there, I will answer at the end of this session. Thank you very much.